Oh, thank you for asking. We were very appreciative of CODF, taking the a front role in Wilson disease, because unfortunately, Wilson disease is a condition that remains very unrecognized. And many patients will be presenting to their neurologists, psychiatrists, internists, and gastroenterologists with really non-specific complaints or signs. And unlike other conditions where you could do a simple blood test or another examination to diagnose Wilson's, to diagnose a liver condition, for Wilson, it takes a high level of suspicion. It takes a combination of laboratory work, of genetic testing, of urinary testing, of even histology to make a diagnosis. So, unfortunately, Abigail, no one wears a badge that says, I've got Wilson's, please screen me. So it does take a high level of suspicion. So we're going to talk about, when should we suspect Wilson disease? What should be our approach to making a diagnosis? When do we use genetic testing? We're going to also touch upon treatment. And we're going to cover an area that tends not to be discussed as symposiums or seminars or even lecture series, and that is how to follow patients and what does over treatment look like. So that's an area that's rarely discussed in meetings is how do you know when you're over treating someone? Papers are rich in highlighting, how to diagnose, but what they lack is long-term data, long-term management skills, and something we're gonna highlight. We're gonna talk also about how to partner with patients to make sure this is a team approach. Because unfortunately, experts in Wilson disease are not very common. So we're going to work together with patients and touch upon all these major unmet needs in Wilson disease, in management, diagnosis, and treatment. Well, great question about unmet needs. I can tell you that there have been some unmet needs met recently, and one of them is giving people freedom with Wilson disease. Many of the transferees had to be refrigerated, put in ice. So we've had patients who travel, and it's a challenge keeping medication on ice. And now we do have a transferring that provides people freedom, so they don't need to be worried about the temperature of the medications. So that's a unmet need that has been recently met. Other unmet needs that we need are something in terms of diagnosis that's more simplified than what we have today. Today is a conglomeration, again, laboratory testing, blood and urine, genetic testing, biopsy, etc. What we need is a simple test that will define whether someone has Wilson disease or not. We also need help is in management. Abigail, we have not gone through the Renaissance period yet with Wilson disease, and we still rely on 24-hour urine collection. Now, I don't know about you, but in my schedule, it'd be very difficult to do 24-hour urine collection and keep the urine refrigerated. I would be kicked out of clinic if I had that container in our refrigerator here. So we need better tools in terms of management. Now, the 24-hour collection has been validated for diagnosis, management, and follow-up. So we are in desperate need of another test that we could use for diagnosis, management, and follow-up. We do use 24-hour collections to define appropriate therapy, under therapy, or over therapy. So an unmet need is having a simple test that could provide similar information. It's just 24-hour collection is very archaic, and it poses a challenge for a patient in terms of adherence. One of the problems I have, I'll be honest with you, is patients don't come back for follow-up. They don't hear, they don't read the guidelines that talk about follow-up. And so they understand the necessity. And just doing the 24 hours isn't short. It's a very difficult process. So, although we would love to see our patients every 6 months, the reality is they may come back every 1 or 2 years because a major barrier is that urine collection. So we have a long way to go. We've come a long way with medications, but we still have a ways to go in terms of having simplified tests.